interfacility transfer this morning. They are available to all participants of the PRQC, and their topics will be of particular interest to those of you who are working on the interfacility transfer bundle. Next slide, Crystal. This is our disclaimer slide in which basically we want everyone to know that HRSA's MCHB is supporting the EIIC, but the content of this presentation should not be construed as an official position or policy or endorsement of HRSA, HHS, or the U.S. government. Next slide, please. We'd like to introduce our speakers this morning. Our first speaker is she's going to be the second speaker, but in alphabetical order. We have Lisa Nichols, who is the Trauma Program Manager for Dell Children's Medical Center of Central Texas, one of 5 Level 1 pediatric trauma centers in the state of Texas. And she's been with Dell since 2015. She works with her team in the development and implementation of pediatric trauma education initiatives, as well as the development of critical pathways and protocols to assure optimal pediatric trauma care for the children who enter in her institution at Dell. Our first presenter will be Dr. Tony Woodward. Dr. Woodward is currently the Chief of Emergency Medicine and the Medical Director for Emergency Transport Services at Seattle Children's. And he's a professor of pediatrics at the University of Washington. He's also the pediatric medical director for the Airlift Northwest, which provides transport and pediatric medical direction to the state of Washington, Wyoming, Alaska, Montana, and Idaho. He's also served as the editor-in-chief of the American Academy of Pediatrics the third edition of Guidelines for Air and Ground Transport of Neonatal and Pediatric Patients. And he serves as one of the senior editorial board members for pediatric emergency care. He has a long history and involvement with pediatric transport, and we are fortunate to have both him and Lisa here with us to serve as subject matter experts for Bundle 3. Next slide, please. Our agenda today, our speakers will cover interfacility transport definitions, perspectives, and goals of transferring children to additional resources. There will be a discussion on transport options and the process that sites should consider as they're moving forward with transferring children. They will talk about transport initiation, the role of transfer agreements, and communications that you all should expect as transferring facilities, as well as the receiving institutions who will be receiving these children. And then they will include a discussion of resources that are available on the website for you all to access in regards to pediatric interfacility transfer. We will then take a few minutes to talk about the data entry system and the elements that are included in the data entry system, and how those elements are defined and how those are important to the transfer process. And lastly, we will cover some questions that hopefully you will feel comfortable enough submitting in the chat box for our speakers, as well as some questions that were received previously. So at this time, I would like to turn the conference or the webinar over to Dr. Tony Woodward. And Tony, when you get to a point transferring over to Lisa, just let Crystal know so that she can give control of the slides to Lisa. Thank you.
Well, good morning, everybody, and thanks so much for having us. I wanted to especially thank Lisa, my co-presenter, for her expertise in this area and helping us put together this presentation, and certainly to Crystal, Diana, and Kate, as well as the entire PRQC for the foresight to bring this opportunity to all of us. We have some formalized slides. There's a few questions that we've received, and we'd be happy to answer any others as we go along. So I'm going to start out with the first part of today's agenda and talk about really what we're thinking about intrafacility transfer and transport. There was some confusion a little bit around the terms of transfer and transport. And the way I look at it is transfer is the process of getting a patient from one facility to another, and transport is the mechanics of how that actually happens. It had to do with the modality and the personnel and those kind of things. So we'll talk a little bit about that, both of those processes. I think as we go through this, recognizing that any time someone needs to have care to another location, it's usually in a stressful time. So like anything we do in emergency medicine, if we can anticipate and prepare for it ahead of time so that when it does happen at the least convenient time for all of us and the least convenient time for the patient, we're then able to do it business as usual. And when we function with business as usual, we usually do pretty well. When we get stressed and have to sort of make it up in the moment, sometimes things don't go as well as we would expect. And to always keep in mind, it's the patient first. It's not about how do we make our systems better, how do we take away a stress in one environment or another. It's about what's best for the patient and how do we manage that with the resources that we have and the resources that we might have available to us. So the definition of interfacility transport is any transfer after initial assessment and stabilization to and from a healthcare facility. And I will try to make this work. Crystal, I don't seem to be able to advance my slides.
Try your keyboard hitting the down. I can see you moving your mouse. There it is.
Okay, there we go. And one of the things that's really important to all of us is EMTALA. And EMTALA is a big deal because it's important for the patient, but it's also important for our systems. If we have patients where we don't live up to the letter of this law, it can really impact our ability to take care of the rest of our patients if our funding for our general patients goes away. So it's the anti-dumping law. It had to do with pregnant patients and neurosurgical patients to start with, but it really is about all patients, and especially with pediatrics, where many people don't feel quite as comfortable with pediatrics if it's not your core competency, but we still have an obligation to treat, assess, and stabilize so that we can ensure, to the best of our ability, the patient does not decrease, their status does not decrease during transfer. So what is interfacility transport? And I think it really varies on who is asking the question and who is getting the response. In general, it's specialized pediatric transport between medical facilities to facilitate care not available at the referring site. And it's not the same as pre-hospital care. I think it's really important, and especially for transport services that do both pre-hospital care and interfacility transport. I think the idea of a scoop and run doesn't work in interfacility transport. In interfacility transport, we have a facility and a facility with more resources no matter where you are for the most part than we have on an ambulance or a helicopter or a plane during transport. So it allows us to figure out with all those three differentials, how do we best take care of the patient. For the patient, it should be that there's safe and experienced access to additional pediatric-specific services and support, which may not be available at the referring hospital. And then for the family, it should be reassurance of experienced specialty care for their child. And when that transport comes and when they arrive at the receiving center, there should be a sigh of relief that we are now stable, we've been stable, we've not gotten any worse, and we have an opportunity now to get care or services that we didn't have at the initial hospital. So the goals of interfacility transport on a macro level are it's to meet the unique needs of ill and injured children and recognize the need for a different level of care. We can't all do everything, and it's really important to be able to identify the things that we can and that we can't do and not look at those as deficits, but look at those as opportunities to partner with somebody else. For example, if you're a small community hospital and pediatric trauma or pediatric intensive care medicine or burn management is not your expertise, it's important to recognize that. Figure out what are those things that need to be transferred ahead of time, whether it be age-based or diagnosis-based or specialty-based, and then figure those things out so that when they arrive at your hospital, you've already had a plan of how we can take that person to the next level to what they need. And Lisa will talk a little bit about transfer agreements and how they might help us get there. I think it's also important to be aware of your hospital resources and limitations. And many of us in the emergency department feel that we can do anything and we're able to manage whatever fire comes in because that's the business we're in. And we probably can in most places. But if your hospital doesn't have the capability to manage that patient that you can manage in the emergency department, for example, if you have some pediatric expertise for a burn patient or a trauma patient, but once they get admitted to the ICU during the nighttime, there's not the same insight of staff taking care of those patients, that's the level of service your hospital can provide. So look at the level your hospital can provide as a global and say, okay, these are the patients that even though I know I can take care of them, they need to go to a different place for their definitive therapy. We want to meet the needs of the medical community so we can regionalize things, but we also want to think about families. And we don't want to transfer families 100 miles away for something we could manage, but we also don't want to keep things that really should be cared for somewhere else and put the patient at risk for those reasons. If we identify there's a potential for progression, we would want to transport the patient prior to that progression if possible, stabilize it, recognize that risk, and stabilize them prior to transport. The goal for all of us is to provide the best quality care we can at the moment of the patients coming to our facility and from the transport perspective at the moment of the call, and deliver the patient safely to the receiving center definitive care in stable or improved condition. I think it's really imperative not to put the patient in no man's land between care at a referring center and care at a receiving center. It puts the patient at risk, and it puts all of us at risk as well. So you really want to make sure that as we look at our opportunities for transport and the ways we can do that, we do it in the most effective manner for the patient first. So one of the questions that we'd received ahead of time is talk a little bit about the different types of EMS and the different types of transport, and I'll go through a couple of those. First of all, sometimes it seems quicker. Let's just put the patient in the car and drive them to the hospital. And I think that's fine if the patient does not have a progressive issue and you know what the issue is. If it's something you're not quite sure about and we don't know what the issue is, then putting them in a private vehicle or a taxi or any kind of ride share, the benefit is they'll go directly to the hospital most likely unless they stop at home and wait for somebody else. But you don't know what the progression is going to be. And even we've on occasion had medical providers come with patients in a car, and it's a nice gesture, but in reality there's not a whole heck of a lot we can do in a car other than CPR. So if we think somebody's going to get sick enough that we need a medical provider, they ought to be in a secure environment like an ambulance. The primary ambulances, however, you have to think about what your area provides, and we have volunteer ambulances with very little medical experience or teaching. We have first responders or police who can do some basic things and are wonderful if you're going to deliver a baby on the side of the road, but maybe not as good for progression of a pediatric illness. Our EMTs and our paramedics. We also have secondary transport or interfacility transport, and this needs to be separated into two types, specialty teams versus non-specialty teams. Specialty teams would be a pediatric NICU team or a pediatric ICU team versus a generic team which covers all patients. Secondary transport are often very skilled in critical care issues, whether they extrapolate from adult medicine to pediatrics or whether they're pure pediatrics, but they're very expensive and they're resource limited. So if you have one of those teams in your area and they're out, there may be a long delay waiting for that team to come in and help. And the bottom line is, are you trying to get specialized care to the patient or the patient to specialized care? And you have to answer that question as you think about your own transport modalities. Am I trying to get the best care to this patient at this moment, or am I trying to get the patient somewhere else? And the second part of that is more like EMS. I'm trying to get the patient from a resource-limited, austere environment of the field to a hospital. But in critical care interfacility transport, they're in a hospital. We should be able, with our personnel, our lighting, our resources, however limited they might be in our referring hospital, to do a better job than we can do in a field situation. So it's a little bit of a different paradigm of transport. People often ask, what's the difference between EMS and transport capabilities? I know many of us on this call understand this pretty well, but it was one of our questions of how do you know what your team can do? And this is a little bit site-specific, but a basic life support system is emerging medical technicians, and overall they're required to have about 100 hours of training. And when you think about all the things you have to learn to be an EMT and all the things that you have to do, pediatrics is not a huge part of that. They can't usually deliver medications or IVs, but they can do things like CPR and breathing assist and basic wound care. Probably not the people who you need to be transporting a pediatric patient with an unknown diagnosis with a risk of progression. Paramedics, on the other hand, have between 1,000 and 2,000 hours of training. Variable pediatric training. When I first started in this business, there was no pediatrics in our paramedic trainings. Now there's a lot of pediatrics, and these folks can do an awful lot, but it really is site-specific and location-specific, the amount of expertise. Critical care ambulances take a paramedic ambulance or an ALS ambulance and add a critical care nurse. In our area, that's often not a pediatric critical care nurse, so then they have to extrapolate from their general emergency or their general critical care experience, and they may or may not have the capabilities to do things that you like use a ventilator. And then your critical care transport teams usually have more critical care education and more critical care experience. They often come from a receiving hospital, so they can help that seamless transition from the referring site to the receiving site, rather than having three similar silos of care with the receiving referring hospital silo of care, the EMS silo of care, and then the receiving hospital silo of care. That team composition for pediatric critical care transport, I think the most important part as I look through this is that there's really not any single best practice. But if there is a single best practice, it's people who are skilled in acute and critical care and have the ability to recognize, assess, stabilize, and intervene where necessary, and also know where they have to ask for help or things that are outside their skill set. It doesn't necessarily follow with a degree. It doesn't mean that your higher degree means you'll be a better transport person. It really is about how much time you've had in the environment and how much experience you've had with that specialty. You have to be competent and capable and licensed, and that's the job of the transport team. But I think one of the things from the transport perspective is that transport is time limited. We don't need to have a sophisticated diagnosis. We don't need to have the absolute final diagnosis. We need to know what the signs and the symptoms are and what our idea of progression is and how long it's going to take to do that. And when we do our transports, I usually say, if you think they're going to be stable for the time of transport, double that. If you think they're going to be stable for double that amount of time of transport, then they're probably stable for that method you're thinking about. If you're worried that you have to really get them from point A to point B very quickly because they might have a risk of decompensation en route, then you might think, is there a better way to transport these patients than what I originally thought about? And I think one of the most important parts of transport is not only the expertise of the people who are doing it and then choosing the right mode of transport, air or ground, but it's who's supervising it. And if you have a pediatric intensivist, a pediatric emergency medicine physician, or a specialist supervising the transport process who understands the transport team and knows what their care and capabilities are and understands the process, then that really is delivering tertiary care to the patient regardless of where they happen to be, whether it's at a sophisticated referring hospital or a 4-bed community hospital. So I'll finish off by just saying, as you think about transport, the goal in transport is getting the patient to definitive care. So when we think about the way this works, we have an injury or an illness. If it's an illness, we may or may not have been able to prevent it. Same thing with an injury. There's initial medical care that's provided. There's the decision to transfer, followed by the hospital and the transport response time. So this is where transfer agreements, if you have a way to streamline that process and make quick phone calls, that can really be helpful. How long does the transport system spend at the referring hospital? Do they come in and have to start from scratch and put in an IV and secure an airway, or have those things been done to the best of the ability of the referring hospital? And then how long it takes, obviously, to get back to the receiving hospital. And then how long it takes to get to definitive care within the receiving hospital. And again, as I mentioned with silos, if we see a patient in one spot, put them in an ambulance, and they show up at the door of the next spot and there's no communication or limited communication, it's really starting from scratch at the receiving hospital. If there's great communication and there's oversight in the process, then the care can start at the referring hospital with the same sort of paradigm it would be at the receiving hospital to whatever the ability constraints might be, continue during the transport process, and then continue right into the receiving hospital. So for our benefits, I think that it's really important to think about that decision to transfer. How do I know who I have to transfer? How do I know when I have to transfer them? How do I figure out how to do this in a seamless and efficient fashion so that there's no delays in our process? We don't want to wait till 6 hours into an ED visit to find out that, we can't take care of that patient. We should have figured that out sooner and then transfer them as quickly as possible. So at this point, I'm going to shift over to Lisa, and then we'll both be available for questions at the end.
Great. Thanks, Dr. Woodward. So again, I want to thank everybody for the opportunity to do this, to speak and stuff today to the group related to transfers. So it's one of those things that unfortunately a lot of places do, frequently, but it's, how can you make that better and how can you make it more efficient? And working on the actual care of the patient itself and making sure that we're not having those gaps in time and recognizing things early. So it's the anticipation. So it's looking at initiation of that transfer and anticipating what it's going to look like when you're getting ready to transfer that patient. And it's not necessarily just that, you make the decision that you're ready to transfer, but you actually have a system and a process in place. And some people will say, even having an algorithm or something written down as far as how you actually make those contacts will actually make that decision-making process a little bit easier as you get ready to actually transfer the patient out. So which institution do you contact? And who decides where you're going to send the patient? Is that a physician decision? Is that, sometimes it's the nurses who have may better well know what the capabilities are at different institutions. And then are there transfer agreements in place? Even if there aren't transfer agreements in place, is there some place that you're consistently sending patients that you want to make sure that they're aware that your patients and stuff will be coming to them? And then how do you initiate that contact to the institution? Who's going to be the person that actually initiates that contact? There's nothing worse sometimes when you're standing in a situation with a child that may not be doing very well, and the comment is, well, we need to transfer this patient to the institution, and the left hand thinks the right hand is the one that's actually making the contact. So it's really making sure that you know who that contact person, who the person who's going to be contacting is, and actually specifically pointing out that that person then needs to initiate that contact and get the ball going, so that actually process and stuff can be happening. Are your phone numbers readily available? So I know for us in particular, we recently had an instance where, an outside facility was trying to transfer us a patient, and, God love them, but they had to Google the number to the emergency department as they were getting ready to transfer the patient because they were not anticipating having to transfer a pediatric patient. So it's kind of having those resources and stuff in place so that you actually know what numbers you're going to be calling and making sure that those numbers are checked on a semi-regular basis to make sure that it's still the number that you would need. And then who's giving report? Instances, there's a lot of times when you're actually calling at either a communication center or in some sort of a transfer center, that somebody can actually be the one setting up those phone calls, and it may not necessarily have to be the physician initially. Make sure that the physician knows that they need to be readily available, but they may be better served actually at the bedside of the patient, and somebody can be connecting with the actual transfer center while the physician is still a physician or advanced practice provider is actually still providing care. So they can actually be making the contacts, getting everything ready to go, and then when it's time to give report to the outside facility, the physician and or advanced practice provider, or in some cases the nurse, will be the one who can actually get on the phone and actually be able to provide report. And then how do they get here? So Dr. Woodward did a great job outlining kind of what the different agencies and stuff are, but which one is the best one for your patient? So, and that's kind of something that you need to kind of have thought out ahead of time as far as what are the capabilities within your area. Can EMS be mobilized at the same time that you're actually on the phone so that they can actually be coming to your institution if there's some sort of a delay? There are some places where it may be 20 to 30 minutes before EMS can actually get to your institution. So is it something that you can get the ball rolling at the same time that you're actually contacting the outside facility as well? Or is it something when the call goes into the transfer center to the hospital that you're going to be transferring to, that they know to then mobilize their transport team at the exact same time that you're on the phone? And it cuts out those few minutes, but sometimes those few minutes make a huge difference. And then if critical care transport team is noted, that you want to make sure that you're starting that process. And again, that goes with that transport service at the facilities that you're contacting, or it may be that you need a critical care transport team that's actually in your area. And as Dr. Woodward pointed out, that may be something that's available, but again, that team may also be out with another patient and not readily available at the time that you're ready to transfer. So it's something that you want to make sure that you're anticipating and you're ready for. But knowing what capabilities are in your area and knowing what people can do and what their skill level is and how they can actually do that is actually going to make a difference in the time that you're getting ready to transfer your patients. Mm-hmm.
Lisa? Okay, I can see you moving the mouse. Try using the keyboard. Try hitting the space bar or enter. Okay, there you go.
There we go. Okay. Sorry. So centralized access in the communication center. So know how to reach each program and what to expect and with whom you'll be speaking. So with many different communication centers, it may be a nurse that you're going to be speaking with. It may be just a call center, and so there's somebody who's there who's actually just there to take the general information. But that's what I kind of spoke to before, that when you're actually initiating that initial phone call, it doesn't necessarily mean that even the advanced practice provider or the physician has to immediately be on the phone, and they may be able to provide bedside care until such a time that you can actually get to a point where you're ready to give report and actually tell another care provider on the other end exactly what's going on with the patient. So, go back one. There we go. So, referral, the referral hospital responsibilities. So, what do we want to make sure that the referral hospitals are responsible for, and that they're actually, thinking about when they're actually getting ready to transfer their patients? So, it's not only anticipating and preparing for the potential needs. So, what is it in transport that they may actually need? What is it that patient is actually exhibiting signs and symptoms of any sort of difficulty? If they have any difficulty at all, or if you have concerns about, an airway, is it something you need to secure an airway before you can actually take off with that patient, even though they may not be in full respiratory failure at that time? As Dr. Woodward stated, it's not something that's easy to do on the road, and you don't have the same critical care capabilities at that time. So it's thinking about what types of things they might need before you actually start to transfer and having those things available. Maybe it's an IV. But having that access and stuff ready to go before you actually head out the door. And then making the appropriate decision to transfer. So there are several patients, and having worked in pediatrics for about 30 years, you look at different patients that get transferred to you, and many times doing ED transfers or being involved in the emergency department and taking those transfers from outside facilities, sometimes up to 30 to 40% of the patients that we actually take will then discharge home from the emergency department. So it's one of those, how can we help institutions understand, which patients are the ones that are the best suited to be transferred at that time? Always err on the side of, you're not comfortable, you don't have the capabilities to be able to fully assess something, but it's also working with those facilities that you're transferring to say, what types of patients and stuff, or what actually happened with this patient, and how can we do better the next time to kind of recognize some of those patients that you may be able to hold within your institution, saving the parents and everyone, the actual expense and or frustration of being transferred to another facility. But you want to stabilize and prepare the patient prior to transfer. So critical interventions should not wait, obviously, for the transport team. If they need to be done, then they need to be done. However, it's also your comfort level, and if it's not something that you're comfortable with, then it may be something that could wait for the transport team if it's something they have more experience with and are more capable of taking care of. So definitely don't delay transport if the work can be safely done elsewhere. So don't delay transport if you think a CT scan, an extra CT scan needs to be done, or other types of lab work needs to be done on a patient. So get the patients out of the emergency department when the team is there, and actually getting them moving to definitive care usually adds much more to their actual patients doing much better than they are if you're actually just trying to get more studies and stuff done at the outside facility. So choosing the appropriate transport process we've talked about as far as looking at that, and then actually looking at the destinations. So and with that destination, does that mean that that hospital is available to take transfers? Is it a hospital that you use on a regular basis and you talk with on a frequent basis, and they're ready to take patients? Are they accepting patients? Are they full? Is it a season by which they're going to need a little bit of heads up, and or they're really full, but they can actually help you find another institution that may be able to take your child? So all of those things are really good to think about and have available ahead of time. And then consenting for transport, making sure that you have consent from the family so that they know that you're transporting, and then from the receiving facility as well, and having that before you're actually walking out the door. Okay. Discuss plans for stabilization and intervention. So if there's something that needs to be done, again, is it something that can be done before you head out, or is it something that potentially may have to happen while you're actually in the ambulance? And then initiating those interventions plan as able. But again, if you're not able, or you don't have a desire to comply with the suggestions that are given, just because they're suggestions, you're actually the one that's actually seeing the child. So if somebody gives you a suggestion by phone, and it's not something that you feel would be in the best interest of the child, it does not necessarily mean that you have to do exactly what it is that they're saying. So, but approaching everything in a constructive manner, and sometimes disagreements can actually, regarding any sort of intervention and stuff, is valid, and it may not be something that would actually benefit the child. You're the one who's actually there taking a look at the patient, Your team is the one that's looking at the patient. So whatever the best interest of the child, and then having the discussion as far as why or why not you don't think that that's a good idea. And then easing transition to the receiving service and trying to help them get out the door as quickly as possible and get them actually on the road or in the air is much more advantageous for the patients in doing transport. So in the receiving hospital responsibilities, so as receiving hospitals, what do you actually need to have available? But you need to make sure that you immediately have people who are available for discussion. So as we talk about, these calling into the transfer center and getting, hookups and stuff with the actual emergency departments where you'll be transferring a patient, I can't imagine as an outside facility there's anything more frustrating than being on the other side and waiting and waiting and waiting for somebody to pick up the phone on the other side. So making sure that as the referring facility or as the receiving facility that you've got a process in place by which you're actually ready to receive those patients, and you have somebody who's available to receive those patients and those reports on patients in a timely fashion. So you have small referring facilities who are actually trying to refer to you, so you need to be available for that discussion and make sure that you're able to provide advice in a timely manner. So accepting patients if capacity. So the other thing is making sure that you're accepting quickly. So, if it's something that your facility is capable of doing, then the receiving facility should be able to give you an ability to accept the patient in a very short period of time, as long as they have capacity or there's not something else that's going on. So I highly recommend also following these metrics and making sure that as a receiving facility that you're actually following these metrics and continuing to try to improve these times on a regular basis so that you actually know if you're having any difficulty and stuff with this process. Any clear and concise expert recommendations and making sure that there's a good S-bar with that and making sure that the person understands the questions that you're asking and the information and stuff that you're providing. Making sure that you have a preparation of your own environment and your staff and everyone is aware that that patient is coming, so that somebody's coming in for, by ambulance and the first person that they see is like, I don't know who that is or where they're going. But making sure that there's good communication and you have a system in place by which you can identify those patients coming from an outside facility, and somebody is there to actually welcome not only the EMS crew, but also the child itself who's coming in, any family member that may be coming as well. You want to organize any additional diagnostics and interventions, and so if there's something that needs to be done that that might have to happen as soon as the patient arrives, make sure that you have that available and everyone is alerted that those interventions may be needed. Ensure a seamless transition and communicate with those referring facilities and patient providers, as soon as they arrive, so that everyone is on the same page and good communication can happen throughout the entire process. So both hospitals' responsibilities is really making sure that the family understands the process and making sure that the family really does come first. So they need to know where they're actually going. So, what hospital is going to be receiving them? What are the directions to get that hospital? What is the best way for them to go? Sometimes even providing somewhat directions, not only on just like where the location is, but what's the best way to get there. So are there transportation options? Will EMS or the transport agency actually allow a patient to ride with them? Can they actually ride in the ambulance? And then if that happens, making sure that on the receiving hospital end that you have somebody who's available if that family has difficulty with transportation, that that social work is notified or other people are notified to make sure that there's actually somebody who can assist with transportation and stuff of other family members or this family member actually being able to get back. Are there hotel or lodging options close to the hospital? Is there a Ronald McDonald House? Is there some sort of facility that's close by that is affiliated with the hospital where the family might be able to stay? And is it something that you can look at getting the room and everything available before the patient ever arrives? And then contact information. When they're leaving from that facility, make sure that you have more than one phone number. So highly recommended of 2 phone numbers just in case. And in this situation, it sounds silly, but I would get 2 different phone numbers that may not be in the same vehicle. Unfortunately, I've had the instance where the parents were actually transporting themselves to the hospital where their child was actually being transferred, and they were both involved in a car crash. So unfortunately, we could not reach the parents because they were both involved in a car crash, and we had no idea who else to reach. So we actually, from then on, actually made the rule that we got a phone number not only of the parents who were coming, but actually of somebody else who was not involved in the actual transport. So there was a way for we could actually get in contact with somebody related to the families. So just something to think about. And make sure that there's somebody there to greet the family on arrival and that people know that the family's coming. So when they come in through the front door, that they don't have to tell their whole story again, that somebody's there to say, hi, we have your son, we have your daughter, we're going to take you to them in just a few minutes, or if you can take them back right away. Make sure that somebody is actually there to greet them and understand and know that they're actually on their way. And then any other needs that they may have, is if it's clothing, if it's food, if there's other, sometimes it's, access to phone cards or something else that they may need, if it's something, an international call or something else that they may need to make, making sure that they have access to that information and what you can do to actually help them with that process. So there are some great resources. I highly recommend looking at this Interfacility Transfer Toolkit. It was actually developed by the groups that you see there, the EMSC, the ENA, as well as STN. But it's actually available at this website, and it will give you all sorts of different actual tools that you can use, checklists that you can actually download and actually use within your own hospital systems to have available when you're actually looking at transferring a patient, and give you great ideas similar to what Dr. Woodward and I have spoken about today, but in order to assist you with actual transfers of your patients. And then last but not least, we have some transport resources here. The American Academy of Pediatrics have evidence-based resources and stuff as far as the best guidelines for air and ground transport, what's the best ones to use, whether it's field transport, and yeah, there's a field guide as well on air and ground transport, but they're great resources that you can actually use when you're actually looking at transferring your patients. And then pediatric emergency readiness, there was an article that was published by, you'll see that lead author is a very familiar name to all of us, with Dr. Kate Remick, but really looks at how pediatric readiness in the emergency department and being ready in that emergency department, as this project and stuff is, really can make a difference in the care of your child. So that being said, I think we're going back to Crystal.
Thanks, Dr. Woodward. And Lisa, what we're going to do is just spend some time giving you a recap of our aim statement, some of the quality measures, and then data. So Lisa, what I'm going to do is take back the keyboard and mouse control from you. And so remember that the collaborative itself has a global aim statement, but each site will also be developing their own personal aim statements as they're working on the IFT bundle. So for PRQC, we are aiming that by December 2019, 100% of our sites implementing the IFT bundle will have a comprehensive plan that addresses the following pediatric-specific components. Those components are the defined process for initiating a transfer with the roles and responsibilities of the referring and receiving centers, a process for initiating the transfer, for selecting the appropriate receiving center, as well as the staff transport service, a process for the patient transfer that includes obtaining an informed consent with a plan for transfer of copies of that signed document, a method for transferring the medical record, the patient's personal belongings, and then lastly, a plan for providing patients and families with information regarding the transfer process, along with details about the receiving center. Our quality measures range from structural to process measures. One of those as a structural measure will be the presence of that IFT transfer plan that encompasses those 8 components that I just mentioned. One of the other structural measures is that each site has established a minimum criteria for patients who should be transferred, be it for medical, surgical, or burn cases to another facility. We will have timeliness measures, so the median time from arrival to transport, some information about the percentage of transfers that meet criteria, minimum criteria as you stated with structural measure 2. We ask information about that transfer information packet, and then we have 2 strongly encouraged outcome measures, one of those being the percentage of transfer patients who were discharged from the receiving center's emergency department, and lastly, the percentage of patients that were admitted and discharged within 24 hours of arrival time. Let's see, Kate, are you on the line? Okay, I'm going to unmute. Kate, is this your line? All right, Kate, try again. Okay, so I've unmuted all of the call-in lines just in case someone has any questions, but what I'll do right now is walk you all through I can't see line 155, Kate. I only see call-in users and a number. Let's try this. I'm going to unmute all. All right, Kate, how about now?
Can you hear me now?
Yes.
Oh, great. Okay, perfect. Sorry. I didn't realize I was muted. I apologize. So I just wanted to add in that when you spoke about the minimum criteria on the structural measures, just to remember that this is criteria based on, so structural measure 2 here, this is criteria based on the resources that are available at your individual site. So this is defined by your site. We would encourage you to define these criteria in collaboration with other leaders and care team providers at your site. So this may be in conjunction with your inpatient services, your specific ED leadership team, and it may even include hospital leadership or surgical services to decide what would be the minimum criteria for patients who should be transferred. There may be age criteria that you establish at your site. It may be specifically just those patients who need surgical intervention, but this is going to be site-specific. So when we say establish minimum criteria, we're not saying that you need to adhere to any particular criteria that we have defined, but this should be site-specific and as defined by you. So I just wanted to clarify that quickly. So this is just a paper version of this particular bundle in terms of entering records for patients who have been transferred. And those of you will remember that on the previous learning sessions, we specifically stated that you may need a stratified sample of pediatric patient visits if you're going to be working on this bundle, because it would make the most sense to at least look specifically at pediatric patients that transferred out to an alternative site, so that you're not looking at all pediatric patients that come to the ED, but those who intentionally needed to be transferred out. So the first question is, how did those patients come into the emergency department? What was their mode of arrival? Did they come in by ambulance? Did they come in by private vehicle or walk-in? Or did they, was their mode of arrival not known? The next couple are related to the date and time of arrival. So just putting in, when they came, at what time they arrived. And that time of arrival is really important because that begins to get at all of the downstream effects that Dr. Woodward was speaking about, which is how long does it really take to recognize them and actually be able to move them out to the receiving site. What's their date of birth, of course, and then their triage level. And those are common elements to really any patient record that we're entering into the data entry system. The next question are related to your site policy, which speaks to the structural measures. Do you have an interfacility transfer policy in place? And then there's a number of questions that go on related to that based on whether or not your answer is yes. And you'll see that on the data entry site. The next piece is when that patient was actually being triaged. And there may be at a certain point here where we recognize that patient has significantly abnormal vital signs that would have met criteria for transfer. And that's all based on the policy statement. The next question is whether or not that patient met criteria for transfer based on that policy statement, yes, no, or maybe that there's no site standard that actually exists for that, which we would then prompt for future change strategies or interventions. Then moving on, was the patient actually transferred? And if they were transferred, what was the reason for that? And then what was the mode of transfer that was chosen for this particular patient? And you can see there's a variety of options there, whether they went by ground or air, whether it was a pediatric specialty service, and whether or not, if ground was chosen, if it was a general critical care service, ALS or BLS. Then moving on to the next slide. Some patients, it's possible that they would be transferred out by law enforcement. This may be, for example, for a mental health patient who's on a emergency detention, or maybe that they're transferred via private vehicle, as that makes sense within a particular community or region. And then, of course, getting into the time that the patient actually departed the site to be transferred out to the receiving facility. We know that there are a number of other steps that are in between there, and Dr. Woodward went over those different steps along the way. When we look back at our actual times related to the process measures, we may notice that there seems to be significant delays based on our benchmarking or reference to other sites who are participating in this bundle. And that would prompt us to then go back and actually look at where those delays might have occurred. But for the purposes of the data entry system, we're not asking you to enter every single time point in the data entry site. If we recognize there was a delay in transfer, then it would be helpful to be able to understand what the reason for those delays might be, which is the reason for question 15. There is an option to be able to write in a potential reason that's not listed there. We then ask about the use of telehealth in terms of determining the reason for transfer. There are two last sections within this patient care record data entry. One is related to the receiving site and getting feedback. And you'll remember that there will need to be a delay in this because we may not receive feedback from the receiving site until several days later. And we've suggested that it may actually take up to 30 to 45 days to actually get feedback from that receiving site. Within any patient care record that's entered into the data management system, you'll also remember that we are not entering our site-specific patient medical record numbers. And so it's imperative that the data steward for your site maintains a log of our system-generated random patient record with the medical record on site. This is particularly important for this bundle because of the potential delays in receiving feedback from the receiving site. So data stored may be able to enter the specific data elements up to question 17, but then would want to go back in and fill in some additional data related to the receiving site at a later time, and that's perfectly fine to do so. Alternatively, all of that information could be collected and not entered until the receiving site feedback form is in fact completed and returned to the original site. But once that feedback is received, the question is what information can we gain from that? What was the final diagnosis at that receiving site? What was the ICD-10 code, if we have that? What procedures were conducted? And these are just general procedures such as, diagnostic imaging might be CT scans or MRIs. Diagnostic procedures could be, for example, lumbar puncture or a joint aspiration. And a surgical procedure might be something like an appendectomy, just to give examples of that. And then the final disposition from that receiving site, were they eventually discharged, were they admitted, were they transferred out, what was the final ED disposition. And then the last section is related to family-centered care and getting feedback from families. This would be done on site at the originating site, so the participating site in the collaborative. And the question would be, given to the family, or this feedback form would be given to the family prior to the patient ever leaving the emergency department. And the question would be, did you receive a transfer packet? What was your comfort level for the reason for transfer? And if you scroll down to the next screen, Crystal, there's some additional questions about comfort level with directions to the receiving center and overall evaluation score. Diana Fenja worked with Kathy Olson to create a feedback form for the receiving site and also a family evaluation form that can be used as a template. It's not critical that they be used exactly as is. They can be adopted and modified as needed to fit your facility needs. They can be added to as you like, but it at least provides a template to begin some of this work related to feedback from families and feedback from the receiving sites. Diana, do you have anything else that you want to add to that?
No, I think the important thing is that we all realize that transferring a child from a facility where where families are comfortable, may have been there numerous times for treatment, and then having them move to an institution that's further away, that's more complex because they've got more resources available, can be a very frightening experience for families. And we as caregivers need to be aware of that and making sure that they get a transfer packet and that they have an opportunity to evaluate the transfer process being employed at the initial facility provides us an opportunity to actually look at what it is that we do during transfer. So the forms were developed primarily as a model, a suggested idea that you might be able to utilize when you're transferring a patient to additional resources, and provide an opportunity for you to continue to improve your transfer processes. And they're all available now, or will be available shortly on the PRQC website under the Interfacility Transfer Bundle. So take them, adapt them to make them work for your institution, and we'll look forward to hearing how you've identified opportunities to improve care.
Great, thanks, Diana.
Uh-huh.
So did you want to field some of the questions that came through, Crystal? Can I turn it back to you?
Sure. So I'm going to open up the chat function, so please feel free to ask the subject matter experts any questions at this time. And give me 1 second. I think we did have a couple for you guys to consider. What specific considerations should staff be thinking about when they're deciding on the best approach for transferring a kid to another facility? So, for instance, the car, ambulance, or air or transport team.
So I think there are a couple of different things that should be considered. Obviously, the stability of the patient and actually the comfort of the patient are things that really need to be kept in mind. Some other ideas that come across, and this comes specifically more from my world of trauma, but if you have a patient that's being evaluated for concerns of child physical abuse or any sort of, concerns about neglect or anything else with a patient, sometimes transferring those patients by private car opens up the ability, for that family to then not go to the referring facility if they don't want to go. So I think those are some of the considerations that you should think about. Dr. Woodward, do you have something further?
No, I think that's good. It's keeping the patient front and center, I think, is the most important thing, is trying to identify what could happen to this patient, what is happening to the patient, and making sure they're in the appropriate situation. And recognizing that when people transfer, often when they come into a hospital that doesn't feel prepared to care for them, or they've exceeded their scope or ability to manage that, it's really, really stressful. And the more we can do ahead of time to build systems that allow people then to just move on to the next system, the less stressful it will be for people who perhaps don't do this every day.
So another question for you guys is that parents often accompany their critically ill or injured child during the transfer vehicle. Do you know of any standard answer to help with advising them yes or no regarding their ride with them with their child, and is there a model communication that we should sort of consider when sharing with families if they can't go on a helicopter ride or ambulance with their child?
Well, I could take that one to start. It's, pediatrics is all about family units, and I think that if we have systems that don't allow families to participate because of culture, we should relook at those and identify where those opportunities are. We studied that a while back, and it was really interesting because the parents said, we don't have a clue what you guys are doing, but we know if you care about what you're doing. And the transport folks said, well, we don't really want parents to watch us because they'll notice if I don't put the IV in right or I'll do something not right. And the parents, that's not at all what they were looking at. They just wanted to know that their kid was getting care from somebody who cared about what they were doing. So it's, as we've transitioned teams to parents involved, it's been a super positive. There are times, however, when they can't come. The space is too small. There's too many providers in whatever the mode of transport is. The parent is so distraught that they now need a caretaker for the parent, and we can't do that. And I think just being straight up with the families helps them understand that situation. And it really is all about the child. It's not about the parent. It's about the child. But it's also about the family unit as much as possible.
Right. I think the only other thing that I would add to that is making sure that you're not saying something before the team gets there and really knowing what the situation is and, guaranteeing that the parent's going to be able to go without really knowing what's going to happen with the actual care team before they arrive. Because unfortunately that can set up a situation whereby you're saying that they should be able to go, but for whatever reason they don't have the capability, they don't have the space, there are other factors and stuff that come into play that the family may not be able to go with the actual transferring facility or transport team.
Any other questions for our SMEs?
The only other thing I will add on is we talked a little bit about as far as doing CT scans in the referring facility. It's not necessary to make sure that you're getting all scans and stuff done, although there are many institutions that are really looking at, and I would really be a proponent for looking within your own systems and your own facilities as far as cloud-based technology to be able to send films prior to a patient's arrival, because again, it's one of those things that kind of lets the referring facility get some of that information ahead of time and have somewhat of an idea as far as whatever those scans or tests and stuff are done that you're able to send ahead of time, gives them kind of a running start. There are many different ones that are coming into play, and many rural areas are actually much better and actually faster at getting these up and going than some of the more metropolitan areas. So just something to consider.
Well, with that being said, we're going to go ahead and end our first Fireside chat for interfacility transfer. The next session will be held on April 16th from 11 to 12 Central Time. Thank you, Dr. Woodward and Lisa.
Thank you, everyone.
Thank you.